people are rolling in. Some people I recognize. I see Sally out there. I see see William. Wow. I'm just going to give a few seconds for people to join in. And sorry I was not there last month. My son was getting married that day. And there was no way anybody would have let me come and do an IDM seminar, although I was trying to say that, hey, maybe I could just finish it and run back up to the wedding. I want to take the first 30 minutes and talk about Lp(a), and I'm going to share my screen, show you the slides. I don't think you can do a show of hands, but how many of you know about Lp(a)? So whenever somebody would ask me about Lp(a), Sally raised her hands, that means she knows about Lp(a). So if you raise your hand, I can know. Okay, and then Kathy also raised her hand, and hopefully Kathy can learn. She is quite knowledgeable about many aspects about heart disease. So whenever people would ask me before about Lp(a), I would deflect because I really didn't know all the details. And I would say I've seen 80-year-old women with normal hearts with high Lp(a). And I have seen 50-year-old men with very low Lp(a) and bypass surgery and heart attacks. And I would say that I really don't think that that we understand it that well. But over the last couple of weeks, I've been looking at it a lot more carefully. And so what Lp(a) is that it's a special kind of an LDL. And I don't know if you can see my cursor or no, but here is an LDL molecule, and that has an identifying protein, which is called ApoB100. And what Lp(a) is that there is a bonding between that protein and this protein of Lp(a), which has kringles. It's called kringles because it resembles the Danish pastry. So it's got multiple kringles, and this particular region, which is colored in yellow, looks like a plasminogen. So I'm going to carry each and every one of you with me today in this presentation. So if you don't understand something, you're going to be explained what it is. So there is resemblance of these kringles with a particular kringle and plasminogen. So this is supposed to act like a decoy for plasminogen and prevent plasminogen from working. So the question is, what does plasminogen do? So this is a blood vessel. This is the lining of the blood vessel here and here. There is some damage because of, let's say, high blood pressure. A blood clot is forming. And when the blood clot is forming, you have the clot, which is composed of fibrin, and plasminogen comes in and gets converted to plasmin and breaks down the clot so that the blood vessel doesn't get completely occluded and stop blood flow. So the role of plasmin is to break down a blood clot. So what does Lp(a) do? So here is Lp(a), and what the Lp(a) that these people imagine does, that is the mainstream medical professionals, is that it'll come here, it'll occupy the site where plasminogen was supposed to be, it'll prevent the conversion of Lp(a) to plasmin. So the plasmin is blocked, and hence the blood clot will propagate and the blood clot will not dissolve. So why is that important? So this is an LDL molecule with the identifying protein. When we already implicate that the LDL molecule is causing plaque buildup in the blood vessels of the body, specifically blood vessels of the heart and the brain. Now, whether this is true or no, I don't want to debate that right now. I want to debate it towards the end of my talk. But you are making LP little a, which is a kind of an LDL, look even worse. And the reason it's worse is that here is a blood clot that is forming. And if your LP little a is low, the blood clot may dissolve. But if your LP little a is high, the blood clot will propagate because the natural blood dissolving mechanisms are gone. And the blood vessel may completely close and end up causing a heart attack. So if LDL is bad, then LP little a is doubly bad, or it's worse, because not only does it cause plaque buildup, but it also leads to clot propagation to such a degree that it would increase the risks of heart attack. So if you go to a doctor and they'll say high LP little a is bad, and they frighten individuals because people who have high LP little a think that they have a kind of an LDL that really equates to a death sentence from heart attacks and strokes. And here are all the bad things that LP little a is supposed to do. It's supposed to cause inflammation. It's supposed to make extra plaque form. This is forming plaques in the blood vessels of the heart. And in addition, it activates blood coagulation and makes you at risks of blood clots leading to strokes and heart disease. Now, you would be surprised to know that LP little a is based on one gene that you inherit from your mother and one gene that you inherit from your father. So if, according to these people, if you're unlucky enough and you were to get 2 copies of the bad gene, that means you are a homozygous. That means both copies make high amounts of LP little a. Your LP little a levels are very high. On the other hand, if you inherit only 1 copy, the LP little a is high, but not as high. And if you inherit no copy, if you were lucky enough not to inherit any copy, or so-called lucky enough, then you would be very good. Now out here are different types of LP little a. Here is an LP little a with those kringles, but the kringles are fewer in number. In other words, the tail is small. Here, the tail is very large. So let's look into that a little bit. The different genes that you inherit from your parents, you can inherit a gene that gives you a small tail of kringles, that's 4. Here is 8 pieces of kringles, so that's a sort of a little longer tail. This is an even longer tail with 24, and here is the one with 40 tails. So why is that important? The reason it's important is that when the tail is very long, you have very few particles of LP little a. So in other words, the amount of LP little a you will have is low, and you're lucky. On the other hand, if your tail is very short, you will have numerous LP little a particles, and that is bad, according to the mainstream medical profession. But here is the problem. When I order an LP little a test, it is done by a certain method called immunoturbidometric. And with this method, it just checks the concentration of LP little a, and through a series of assumptions, it tries to come up with a particle number. So in other words, it's not telling me how many particles it has. It's just telling me how much of the mass of LP little a that they are seeing. So these tests don't measure particle number directly, they infer it. Now, why is that important? Why is it important for us to know what the particle number is and not the total mass. The reason is that if you have high particle number, which is what molar concentration means, which is usually people with fewer crinkles, a smaller tail, you supposedly have higher risks of heart disease. On the other hand, if you have a longer tail or numerous crinkles, you will have lower molar concentration and lower risks of heart disease. Now, this is commonly told to you by physicians, and when you read the papers, that Lp(a) are genetically determined. You have inherited it from your parents, that they change minimally with inflammation, with diet, with exercise, or fasting, that high levels cause heart attacks and strokes, that statins should be prescribed even though they increase the Lp(a) levels. Now, this is very surprising to me. And this new group of injectable drugs, the drugs that you inject into yourself, which is PCSK9 inhibitors, should be considered even though there is no direct evidence other than real conjecture that they help. In other words, when you use PCSK9 inhibitors, you do reduce the Lp(a) levels, but there is no real direct evidence that they help so far. But basically what they're telling is that you're doomed if you have high levels, period. Not much you can do about it at this time. So this is one garbage paper. Well, I shouldn't call it garbage, but this is a paper that came out in 2014, I think, and it says that lipoprotein A levels do not change with fasting or non-fasting, do not change with inflammation. And basically they said that the ability of elevated lipoprotein A levels to predict heart disease is very good, and that they are not affected by inflammation or by fasting or by food intake. Okay, now I want to kind of go a little bit off tangent. I thought we are not ready for this information yet, but it kind of fits. Now, statins are supposed to be wonder drugs, and Lp(a) is supposed to be very bad. But would you be surprised to know that statins increase Lp(a) levels? So here is Lp(a) levels. Here is the group that is not treated with statins. Their Lp(a) levels do not change. Here is the group that is treated with statins, and their Lp(a) levels go up significantly. On this side is oxidized Lp(a). In other words, it's gone through burn injury. And that is also increasing with statins. So not only does it increase the regular Lp(a), but it also increases Lp(a) that has been oxidized. Now, I couldn't resist but add this on, that in the same study, they found that statins, when used, caused insulin resistance and metabolic syndrome in that study. So it's interesting to know that statins are doing two bad things. One is that they're increasing Lp(a) supposedly, and number two, they are causing insulin resistance, and number three, they are increasing oxidized levels of Lp(a), and yet they are good. Now, as if the final nail needed to be put in the coffin, here is a study in which they did all kinds of genetic analysis in the general population. And they said that if you have genetically elevated levels, you are at increased risks of heart attacks. Here are levels in the 95th percentile range, 117. Your odds ratio of having a heart attack was almost closer to 3. So in other words, you are 3 times as likely to have a heart attack as somebody with low levels. And here is the number of crinkles. If you had lower number of crinkles, you would have higher levels and higher risks of having a heart attack. So really, basically, if you stop if somebody comes and stops listening to me at this time, they'll say, let me go check my Lp(a). If it's high, I'm doomed, I'm dead. But let us see if I can help you do a little bit of critical thinking and critical analysis. So the basic question that one should ask is, what does Lp(a) do? Does it have a biologic function? Does it do something beneficial in the human body? Why did we evolve into it? Because only primates have it. Other animals don't have it. So here is a beautiful study. They said that Lp(a) goes to an area where there is wounded tissue. So there is a role of Lp(a) in helping wound heal. So here are different stages of wound healing. This is the first stage in which you had an injury, and that injury leads to bleeding and clot formation. So out here is a blood clot. And in addition to the blood clot, there are cells in there that cause inflammation, but the inflammation has not set in here. It's just blood clot with fibrin. The second stage is inflammation, in which these are blood cells like monocytes and macrophages that are causing inflammation. These are blood cells that say, hey, we need scar tissue in here. We need to cover this wound that is now covered with a scab with new skin or new lining of the blood vessel. Then this is a later stage of inflammation called repair, in which a new lining is being formed, but the scab is still there to protect the new lining. Blood vessels are growing in here and creating scar tissue. And here it is scar tissue with some blood vessels, and the lining, either the skin lining or the blood vessel lining, is complete. So let's take a little look closer. So these are a little out of order. So this is the first stage. This is a blood clot. Blood clot consists of plasmin, fibrin, and blood cells. This is what we had discussed. But when you stain this in the study with Lp(a), you find there is no Lp(a). So in other words, in the initial stages of blood clot formation, you find very little Lp(a). So it's really not interfering or making the blood clot dissolve. Now, this is the second and third stage. In the second and third stage, you don't want this fibrous scab, which is composed of fibrin, to get dissolved, because if it gets dissolved, then the healing part is exposed. This is when you find the Lp(a) covering and protecting the scab. And the protection for the scab continues while the new lining is being formed. And then there is a little bit of Lp(a) in the interior of the wound in order to prevent an excessive amount of blood vessels from forming. And then finally, when you go back to the healed stage of the wound, and this is the healed stage of the wound, there is scar tissue, there is new epithelium, the scab is gone. But is there Lp(a) in here? No, there is no Lp(a) in here. So one could say that Lp(a) was designed by the human body as a method to help with wound healing. Okay. Now, is there any evidence that low Lp(a) could be potentially harmful in causing cancer deaths and causing all-cause mortality? So here is a Japanese study, the JMS cohort, in which basically these were a medical school cohort, mostly physicians. There were about 10,400 of them. They were recruited at age 55, and they were followed for 4,599 days. In case you're wondering how many years that is, that's about 12 years. So what did they find? Now remember, I told you that high Lp(a) should cause death from heart disease and strokes. But these guys found that high Lp(a) levels protect you from cancer death. So they found the exact opposite. So here is high Lp(a) levels from 80 to 270. And the death rate, the all-cause mortality is falling off a cliff. As Lp(a) levels are getting higher, as Lp(a) levels are getting lower, these people should live forever. But you can see that their risk of dying is increasing. So what this group found was that a low Lp(a) level would cause a higher risk of dying. It would cause a higher risk of cancer deaths. And even, although not significant, a higher risks of cardiac death. So this is exactly the opposite of what I told you in the beginning, that if you had high Lp(a) levels, you're doomed. On the other hand, these guys are finding that high Lp(a) levels are protecting you from cancer death. Now, this is a study of French centenarians. Centenarians are people who live up to 100 years. So you would expect, if the mainstream knowledge is correct, that these centenarians should predominantly have low Lp(a) levels. The exact opposite was found in this group. In this group, if you look at people with smaller isoforms, that means the smaller tails who would have the higher Lp(a) levels, what we find is that the centenarians had smaller isoforms and higher Lp(a) levels, because the centenarians are represented in hatches. The controls are represented in dark bars. And this is exactly the opposite of what we have been taught, that high levels are associated with longevity in this group of centenarians. So it's not incompatible. Are there additional benefits? So this study looked at high lipoprotein A levels and low risk of bleeding. So we said that high levels will kill you. But this group of people found that in over 100,000 people recruited from different parts of Copenhagen, what they found is that, and permit me to simplify the slide for you. This is an odds ratio slide, which means that if the numbers came on this side, your odds of bleeding are lower. If the bars came on this side, the odds of bleeding would be higher. So the higher the Lp(a) level, the lower the risk of bleeding. So this is the general population. This is based on the size of the tail, because lower the tail length, more would be the amount of Lp(a). And then these are genetic people, a different type of a gene that increases the amount of Lp(a) in the body. And even these people with very high Lp(a) levels were found to have a lower risk of brain bleed and lung bleeds. Let's say you ended up in a motor vehicle accident and had head injury. If you had high Lp(a) levels, you would have lower risk of bleeding. Now let's examine the so-called genetic mutant. So in other words, we said you inherit one gene from your mother and one gene from your father. And if you were unlucky enough to inherit this particular gene that increases the amount of Lp(a), in other words, you were a homozygote, you were a lot more protected from bleeding. Okay, what about the myth that Lp(a) is genetically determined and it doesn't change with infection, with inflammation? So here is a study in which, and this study, by the way, was done in the 90s. So the person who wrote the article in 2014 saying that Lp(a) levels do not change with inflammation or with food intake or with fasting should have read this paper. And in this paper, he says that he took a group of people who were undergoing surgery. So these people were going abdominal aortic aneurysm surgery. I'm sorry, I forgot to put that in here. But what you found is that during surgery, and here are the CRP levels. The CRP levels after surgery go up and come down over time. And look at Lp(a) levels. They went from a little over 40 to close to 100 at roughly a little less than 10 days and came down. There is a 2.5-fold increase in the amount of Lp(a) in this group of people who are undergoing surgery. What about the people in the study who had a heart attack? So this is one representative person. This is days from a heart attack. These are Lp(a) levels that are measured through a certain technique. And look what happened on day 10. There is a dramatic increase from 48 to 107. This is not a minimal change. Now, if you go back and look at this slide, you notice that the peak of CRP, which is a marker of inflammation, is happening perhaps at about 2.5, 3 days. But the peak of Lp(a) is a little delayed at about 9 to 10 days. So the person who gave the later study in 2014, having the advantage of 24 years of knowledge from this study, did not design it properly. Now, here is another piece of information that Lp(a) levels fall dramatically in patients who are in the ICU with severe septic shock. So let me tell you what septic shock is. You come in with a severe infection, like a COVID infection, like with the SARS-CoV virus. You are on a respirator, you have elevated white count, you have severe inflammation. So in other words, you are kind of on your deathbed. And in these people with severe infections, the Lp(a) levels fall dramatically. Not only do Lp(a) levels fall dramatically, but the LDL cholesterol levels also fall dramatically. Now, this paper is not very clear as to why that happens. But I would like to submit that both LDL and perhaps Lp(a) are host defense mechanisms. These are mechanisms through which we are fighting infection and inflammation. And perhaps in the setting of severe infection, these are being consumed. Now, there is a weak argument in the study that it's not actually the consumption of the LDL in the process of dampening inflammation and fighting infection, but that the liver is not producing any because of inflammation. I don't think that argument is convincing, but some people might be more inclined to believe that. Let's look a little further. As the infection and inflammation got better, so here is Lp(a). What happened to Lp(a) as the infection and inflammation got better? They went back up. Actually, they went back up in this case to 120, here to about 50. So there was a significant rise in Lp(a) as these subjects improved from infection, along with a rise in their LDL levels as well. If you go back and look at the people who came in with this kind of an infection who died, the people who died on presentation had almost zero Lp(a) in this group, 0.4 in this group, and almost absent level of LDL cholesterol. So having low levels of cholesterol if you have a severe infection is a bad prognostic sign. So let me kind of talk about the benefits. The LP(a) benefits is that I think it has a biologic role because I want to do some critical thinking here, that there is evidence that it helps with wound healing, that high levels cause lower cancer deaths, that high levels reduce all-cause mortality, that high levels are associated with reduced brain and lung bleeding. And unlike what is taught, the levels fluctuate with infection and inflammation, and perhaps also with fasting and nutrition, as well as during heart attacks and surgery. And perhaps the LP(a) is a firefighter rather than an arsonist. It's going to the site where there is injury in order to help repair it, in order to help dampen the inflammation and not cause further injury. Now, LP(a) is perhaps malign because it's a specialized LDL. So there is really a presumption that it is bad. And I think pharma is always looking to find some culprit to make money without completely understanding what a certain biologic substance does. Now, what they base it on is that when you have high LP(a) levels, and here are LP(a) levels, and they are going high from the tertiles. This is the lower levels, these are the higher levels. Here are levels of inflammation. So this is the inflammation group. So as inflammation is increasing, if the LP(a) levels are high, then you are at higher risks of heart disease death. So this is an association, and by no means is this wrong. But the way to frame that argument perhaps is that the LP(a) levels are high, not because they are causing the injury, but because they are there to help protect us from the injury. So instead of being the culprits, they are the firefighters. You would not blame that the firefighters caused the fire. So if you want to explore whether LDL cholesterol is good and what the benefit it does, I want you to go to my YouTube talk out here about the LDL, whether it should be called the bad cholesterol. If you want to go and look at whether LDL should be considered as an injured fireman rather than an arsonist, I want you to look at this talk. And the reason I'm pausing here to explain this is that these talks have gotten very little visibility because I'm sure I'm so nerdy that I'm not very popular, and people give up in terms of trying to understand some of the biology that I'm trying to explain. So right now we are faced with the sheer madness, and I think this is my last slide. And the sheer madness is that we think that high LP(a) levels are bad. So I'm trying to get my cursor here. And in order to reduce LP(a) levels, even though statins increase LP(a) levels by about 20%, we should use them. And that agents like that new drug, the PCSK9 inhibitor, and old drug called niacin reduce it by about 20 to 30%. People are even interested in taking your blood out and taking out the LP(a) through a machine and re-injecting it back into you without really understanding what it is. And there is this new group of drugs which actually go and trick the liver into stopping making LP(a) that is being in investigational pipeline and trying to get marketed pretty soon. So my final comment to you is that perhaps LP(a) is not as bad a molecule as we are thinking that it is, and that there are benefits in terms of wound healing, lower cancer risks, longer life, lower bleeding risks, and perhaps it is misunderstood in the setting of heart disease, heart attacks, and strokes. So I was a little bit more efficient than I thought. I'm going to stop here. I'm going to take a look at both the question and answers and the chat box. So let's take a look at the chat box.